move this side over to the edge of the hole. There, that's good. Now, if I ask her to take her knee and bring it to her chest and hold it, what's happening to the innominate on this side? Which way does it want to go?
Posterior.
Posterior. So if I hold this like this, but now I take the other innominate and I do this, which way does this innominate want to run? Anterior. So I've got one innominate that's going which way? Posterior. This innominate going which way? Okay, can I just apply, or is there counter stress, counter torque within the innominate? Yes? This test is a great test for evaluating the SI joint. Ask the patient to turn onto one side. Turn on two sides. Now, the side that you want to evaluate in this case is going to be going up, similar to like the one that you'll be pulling off the table. So now you can ask the patient, take your lower leg, you can bend your knee into the chest and hold it. Now while she's doing that, you can do this. That's how you perform a Lewis game. But do you see how it's really not any different than doing a regular game than just rolling them over onto the side? Let's say I want to evaluate this SI joint. If I stand on the opposite side, I take my semi-lunar glue, place it on the unaffected PSIS. Take my fingers, spread them across the affected SI. I don't want my fingers like this. Spread them out, you cover more surface area. The PSIS and this. Bend the knee, go under the knee. Now I'm going to start to lift the leg up like this. As I lift the leg up, what am I doing to her quad? Watch the direction the innominate's going to go. Anterior. So am I causing motion in the innominate? So in doing so, I'm going to reach a point that the SI is going to start to move. I should be able to palpate that movement. When I feel it, it's at the time that the patient reports to me that their discomfort comes on. Is that similar in design to doing golf legs? It's palpable. Now, if pain came on before that even started to move, what's the joint below the SI joint? Femoral joint. Right? Any question about doing a Gilly? Of orthopedic testing doesn't stress the SI joint enough. So what we need to do is, instead of doing it simultaneously, we need to do it bilaterally. Now what are we actually doing when we do this? With the knee bent to 90 degrees, I'm then going to externally rotate the leg. Well, look what happens to the hip. See how the hip comes up? I'm just going to hold the hip down. And I'm going to externally rotate the leg. And when I do so, I'm forcing the femoral head to internally rotate. So I'm getting external rotation, internal rotation of the head of the femur into the acetabular. It presses into the acetabular and presses the SI. This is it. It's called the hip abduction stress test. And this one here, folks, the patient is sidelined. Ask the patient to actively abduct their hip, get on it, and say resist. That's hip abduction stress. Not at all what you would expect. Iliac compression test, folks. Now, if you don't watch, you miss it. Up on your left leg, up on your right leg. What do you think they call that?
Hopping test.
Hopping test. There you go. Very nice. A la guerre is a forbear in the air. So what's your question? I knew that would be your question. Here's a forbear. Forbear stands for flexion, abduction, external rotation, and extension. Anyway, you can see what we did. Flex, abduct, externally rotate, and extend. This is a forbear. So what's a la guerre? Right. flex. Abduct, sternly rotate. What's the difference? Lagaire? Lagaire. Now, can I have you, you know what? Let me have you come. That's the other supine. Okay. Next test is called Minel. Now, what you got to do here, folks, is this. You're going to take your thumb, and you're going to take PSISs. Now, when your thumbs are on the PSISs, you're going to take your thumbs and you're going to push them from lateral to medial. Now, when you push your thumbs from lateral to medial, what are we doing to the SI joints? Compressing it. If the SI joint was inflamed, would that be painful? Yes. Now, the reason I asked about skin on skin for this, because the second part of the test is if that is not discomforting, you're going to go about 1 inch medial to the PSIS. You're going to push down, and now you're going to pull your thumbs apart. When you pull your thumbs apart, there is a myofascial component to this test. So if that's painful, it's a myofascial restriction. Then you can do things like friction massage and everything else. So, Minel, pretty easy test. Two tests folks. The SI stretch test and the Yeoman. Always go hand in hand. So, you want to know about follow-up tests. If you always do a Yeoman, then you got to follow it up with an SI stretch test if it's significant. If you do an SI stretch test, then you got to do a Yeoman. So let's do a Yeoman first. A Yeoman looks like a knockless, but goes a little bit further. This is Yeoman. Now, what am I doing to hurt the quad? What is the direction the innominate wants to go? U-bend. Okay? So I'm going to cause some motion. As the innominate goes anterior, it goes anterior and spreads. These patients that have true SI pain are going to feel it deep and anterior. Now, flip the patient over to the other prong. This is called the SI stretch test. You're going to do a cross, what looks like placental. You're going to get on the patient's ASIS here, ASIS here, and you got to square your shoulders. Get down like this, and you're going to spread the pelvis apart. This way. Can you see how we're widening anteriorly? And if we widen it anteriorly, can we stretch those anterior structures? Can you see why those two tests always go together? So, what you're going to do is take out a skin marking. And you're going to palpate the patient's ASIS, and you're going to place a mark. Place a mark on the other end. Now, go down to the ankle. Take a look at the medial malleolus. Place a dot on the center of the medial malleolus. Place a dot on the center of the medial malleolus. Now, you're going to take your tape measure, and you're going to measure from the first dot to the second dot, first dot to the second dot. This test will tell you if there is a short leg. Now, I want you to hear how I'm going to word this to you. The actual leg length takes into account pelvic obliquity. What do I mean by that? Watch what happened. This was her leg. This is the one that she had a short leg on because the innominate went PI. What happened to the ASIS? Which way did they go? So therefore, the innominate did this. The leg went which way? Up. So this takes into account pelvic obliquity, pelvic subluxation. As the leg went up, the innominate went up. The opposite test happens to be called the apparent leg rest. You still use the same two dots here. But yet, hold it at the belly button, medium malleolus, medium malleolus. The apparent leg length does not take into account pelvic obliquity. Why? It's above the innominate. Alleys or alleys. Square the patient on the table. You don't want them kind of offset. Hold on to their ankles. Ask the patient now to bend their knees. Bend your knees. Notice I brought both feet up together. And what we're going to look for is follow the femur. There's one knee going more this direction than the other. If it does, then we've got a problem in femur height. Follow the tibia and fibula up this way, and it's truly the tibia that has the connection really over here with the knee. Let's do that. Bring straight up. Look, there's one knee going a little bit more this way than the other one. If it does, then we got a tibia problem. Call the ankle test, folks. Raise the leg up a little bit. Hold on to the heel like foot like this. Take your heel, your hand, strike the heel. If you hit at the ulnar side of your fist and the knee is locked, where does all that force end up? Any questions? Hip joint pathology, would that be painful? Okay. Ortolani. Now, this is the one after the baby is born. And the baby's cleaned up and given to you. The baby's laid down on the table. You take your thumb behind the baby's knees, place your fingers on the thighs of the patient like this, and you're going to, what it's going to look, I'm going to show you what it looks like, then you're going to break it down into its two parts. It's going to look like this. That's as quick as it's done. It brings little smirks to people's faces. I don't know why, but what you're doing is you're basically flexing and abducting at the same time. It looks like this. What we're looking for is an audible or a palpable click, and it's telling you that we are locating the dislocated hip. Position. What we want to do is evaluate now, see if it's stable. So a telescoping test, I'm going to hold this side down, and I'm going to work on this side. I'm going to go from posterior to anterior. Look at how much joint play I've got. See that? Now compare it to the joint play on this side. Look. You see the mark, the difference? This side has a lot more joint play than this one. If this was the side that I'm doing my ortolanics and had a click, it would tell me that this is rather unstable. Barlow, you do this. And you may want to do this a couple days after the patient's had their hip retracted on the ortolanics. So let's go back to your office. You do this. Posterior to anterior, anterior to posterior. Posterior to anterior, anterior to posterior. What we're looking for is a click. Now, the way I learned it is that when we hear a click, we're once again relocating a dislocated hip. This basically is telling you that the hip is what? Unstable. I've seen a couple of sources recently where they were saying that if you do this on a hip that's been relocated, you may in fact dislocate it and not look like you click your hip. Either way, folks, it's unstable. And then that person's going to need to be referred to some kind of bracing test. And that's called borrowing. Ladies, probably not a problem. Guys, tight hamstrings. You serious? Yeah, stretch them arms. Okay, hamstring contraction. Hold this, the hyperextension hip test. On the side opposite that you're standing. Bend that knee. Bring your hand under the knee. Place your superior hand on the PSIS. And now as you try to lift that knee off the table, where's the first place motion is happening? Hip. We're putting extension into it. does the leg. Keep the knee straight. Now, what we're ultimately going to do, folks, is we are going to drop that leg. We want it to drop. So the patient knows we want it to drop. Let it drop. What we're looking for is, does it drop smoothly? Does it drop like this? Or does it drop posterior to where we started? If it dropped cogwheelish or posterior, it's due to a tight iliotibial band. It'll come up. Rectus femoris contraction. See it happen right there? Okay? Any questions? Okay? Now, if it stays straight or goes up, that's normal. If when they lift the leg up, the hip drops. So it looks like this. It's hard to do it that way, okay? That means the glute medius on the side that you're standing on is not functioning or doing its job. To A to B, B to A draw. Bend the knee to 90 degrees worth of knee bend. Affix the ankle so it doesn't go anywhere. Place your hand so that it goes in the popliteal fossa, and your thumbs on the tibial tube, and we're going to pull from posterior to anterior. If we feel like the tibia is coming along with us, that means we've got some ACL laxity. Does that make sense? If we go the opposite direction, we're now going to push from anterior to posterior, and the knee kind of gives away, and we see some change in contour, PCL laxity. Any question about the A to B, B to A draw? If I also now add 30 degrees worth of ankle rotation here, which will rotate the tibia as well, when I pull from posterior to anterior only, it evaluates the ACL, but with the addition of that rotation of 30 degrees medially, I'm also evaluating the lateral collateral ligament. Now, about 15 degrees outward, and pull again from posterior to anterior. That's the same test. This is called Slocum. What happens is that we're evaluating the ACL, but with the lateral rotation, we also evaluate the medial collateral ligament. And it shows you why Lachman's test is considered the best test for anterior cruciate. So, what you're going to do is you're going to have the knee bent to about 20 to 30 degrees. So with the knee bent, you're going to fix the leg like this and pull from B to A. That's the entire test. At 20 to 30 degrees worth of knee bend, the ligaments in the knee are normally at their laxest. Normally. So, if you now have a situation where it would be normally at its laxest, and it's more lax because of damage to the ligament itself, this will bring out a more subtle ACL damage or tear. This is called Lachman. If you bend the knee to 90 degrees, place your knee on the back of their thigh and rotate it so it's like this. Now you can push down and rotate. Push down and rotate. All motion is happening where? At the tibia and femur. Nothing happening here. So this is a compressive test, and if I rotate the leg medially, which menisci do you think I'm working? Lateral. And if I rotate laterally, which menisci is being stressed? Now, if you want to now do a distraction test, place your hand like this. You can place your hand like this, and now distract up. And now when I distract up and I rotate medially, which collateral ligament am I stressing? The outside one, which would be the lateral collateral ligament. If I rotate laterally, medial collateral ligament. Now, this next test called the bounce home test. This test, with its sister test called the knee drop test, is going to test for internal knee integrity. Are the menisci doing okay? Is there fluid in there? What you're going to do is grab hold of the ankle, place your hand under the knee. Get the patient to relax. When the patient's relaxed, let the knee drop back into full extension. It should be a nice, crisp infield. If there's internal knee derangement, fluid in the knee, or in some cases even tight hamstring, it'll prevent it from going back crisply. Take your fist, just like this, place it underneath the patella so that it's pulling the leg up. Bend the knee, but not to 90 degrees. Get them to relax the leg. Let me hold the leg, relax it. Let the leg drop. Let the leg drop. Let the leg drop. Cooperative patient. Let the leg drop. Can you see how this is the same test as done with the patient with supine position? Gravity is assisted movement. We're talking milliseconds, folks. I have yet to see it. So take the patella, move the patella down, release it, and look to see how fast it bounces back compared to the other. The fluctuation test makes a little bit more sense. And if you look at it from that perspective, you can create a fluid wave. Take this hand, place it above the patella, this hand, the inferior part of the patella, and all we're going to do is fluctuate hand pressure. If I push down here, and I'm light with this hand, the fluid goes to this hand, doesn't it? If I push here, the fluid's going to go which way? Back up. I've lightened up. So by constantly shifting pressure like this on the knee, what happens? The fluid's going to move up, move down, move up, and move down. Clark's test. This is the one that may be somewhat discomforting to your patient. If you take their patella, superior pole, we're going to force it this way and this way, and hold it there. And now while I'm holding it, ask the patient to tighten their quad. Come on now. Come on. He's not really working it. What happens is you'll probably feel grittiness, crepitus underneath your hand. That's a good sign. The other meaning is a sign for CMP. Most patients that have this, and they don't know they have it, as they start feeling pain, they stop the pressure with their leg. They won't do it. And if you still think that it is CMP, but you're not getting it, you can do it at 30 degrees, 60 degrees, 90 degrees, and knee bend. Press it, hold it, as in the contractor quad. It's called Fouché. Clark's and Fouché always go together. If you all want to know about follow-up tests and stuff, watch this. Get on the patella. Push the patella down into the patellofemoral groove, and now grind it in the groove. You're going to move it from lateral to medial, medial to lateral. If you feel crepitus, or the patient stops you from doing that because it hurts too much, that's a classic sign. Ask the patient to bring their feet together. You're going to get a couple of different ways this is going to happen. Put their feet together. The ankles may touch first. The calves may touch. The knees may touch. What you're looking for is basically the ankles, the calves, and the knees to touch at the same time. If they do, if this was touching here, you'd have what looks like a diamond here. There definitely would be a diamond between the calf and the knee. And if you looked a little further up in the thigh, you would see another diamond. 3 diamonds means you've got perfect legs. Okay? That's what they used to use as for leg models way back when. In the meantime, in real life, if you take a look, if I bring my legs together and my ankles touch, you notice my knees do not. This is a varus type of position. You learned from Dr. Kitterman, varus the pig, right? So therefore, if I do this and I have this, and I take a tape measure and I measure the space between my knee, they like to go somewhere between 9 and 10 centimeters, which is about 3 inches worth of space. Anything more than 3 inches is a true genuvarum. Now there are those people, if you take a look at some of your markedly overweight people, When they walk, or when they stand, they're standing like this. This is their normal position. So they've got their knees touching first with, again, 9 to 10 centimeters from the ankle. That would be a genu valgum position. It's observational, and then you can take the measurement. If you ask her now to raise that leg up off the ground, what does she have to type? Quad. The quads go over the patella. If she had a fractured patella, would that be painful? So therefore, if I said to you, I'd like you to figure out how to do a test like Kaplan on the knee, how could we do that? What was Kaplan's test? Do you remember? Yes, Dr. Lund. What were we checking for with that test?
Lateral epicondylitis.
Lateral epicondylitis. Yeah. And if the patient had lateral epicondylitis and squeezed the dynamometer, what did we do in order to take some of the tension off of the tendon? Did we not go about an inch below? So in this case here, if I then went about an inch above the patella, and I did this, and just held on to the side, and now said to the patient, now lift your leg up off the table, I should feel the tightness coming from the quad. I'm reducing some of the tension as it goes over the patella. Should this patient be able to raise that leg up a little bit better, either higher or maybe a little bit less discomfort?
Sure.
This test is called Dreyer's test, and Dreyer's test is a similar test to Kaplan's test. And this test is designed for what? Fractured patella. Before the leg goes into full extension, if the patient has a vastus medialis weakness, it's going to look either jerky or it's going to be at a different speed than what was done from the first 60, 70 degrees. So you don't want to do this. No. You want to show it nice and controlled. So you go from here to here, straight out. We're looking in this area here. Extension lag indicates the patient has a vastus medialis weakness. Let's do a hyperextension test. 2 times, please. If I grab the patient's ankle like this, and I lift up like this, if he had PCL laxity, what would happen to his knee on that side? It would drop back, wouldn't it? So you could use a hyperextension test along with the A to P, P to A draw as a follow-up and confirm if there's some laxity in the PCL. Patella apprehension. Which way will a patella want to subluxate?
Lateral.
Lateral. If we have a vastus medialis weakness, okay, and it turns out the patella tracks laterally to begin with. When the patella goes lateral and dislocates, and I've got a nice picture of that for you to show you on slides in this class. If the patella is back to where it belongs, and you take your thumb, get on the patella, and now push the patella in the direction that it dislocated. What are we going to look for on the face of the patient?
Grimace.
You bet. Signs of apprehension. Signs of remembering this. Patella grind. Yep, it looks like a Fouché. Get on the patella, push down, grind it medial to lateral, and then you do it at 30 degrees as well. Push down and grind it from medial to lateral. We're looking again for CMP. We've got 2 non-congruent surfaces, your tibia and your femur. When we go from 90 to 0, the tibia is going to rotate laterally in order to help make it fit a little bit better. Does that make sense? So that's called your screw-home mechanism. What you're going to do, there are 2 tests that involve this. One's called the Helfet pivot shift test, and the other one is going to be called the screw-home test. The only real difference between the 2 is one is active and one is passive. The active test by the patient is Helfet pivot shift. You're going to take a skin marking pencil, and you're going to mark the patient's center of their patella. palpate the tibial tube. Mark it. At 90 degrees, it should be one on top of the other. Then you're going to ask the patient to do this, and the tibia is going to rotate laterally. So instead of that dot in the tibial tube being right under, it's going to be lateral. Does that make sense? Here's the problem with the test, folks, is that what we marked was skin. What's moving laterally is bone. So therefore, even though you've marked it, it may be a good idea to palpate it. So now, as the leg goes from here to here, you can feel the tibia rotate laterally. That's called helped pivot shift. The screw home mechanism, very similar in design. Dot it, dot it. Place your finger on it. The difference now is that you, the doc, grab behind the ankle, and you're going to do this on the patient. You should still have a lateral deviation. Normal screw home mechanism. This is called McMurray. Grab the ankle under the knee. It's going to look like this. That's the test. So what you're going to do is this. Start with your hand on the ankle, hand under the knee. Flex it. abduct. Take your hand out. Valgus stress the knee. And as you're maintaining valgus stress, go into extension. And I want your fingers pointing straight up, not on top of the knee. What we're looking for is a clicking or a popping coming from the medial side of the knee, indicative of a medial meniscal tear. I don't want to see the leg dropping onto the table. It stays up off the table, fingers are straight up. As you're going into extension, you have to lower your body as well. That's now in the knee, folks, we have plica or plica that produce synovial fluid. Sometimes we have an overabundance of plica or plica. So what happens is that when the knee goes from 90 degrees of flexion to 0 degrees of flexion, somewhere between 60 and 45 degrees, you end up getting entrapment of this plica or plica, and it hurts. So what the knee does, in order to make it hurt less, is it kind of shimmies from side to side. So if you hold on to the patella like this, ask the patient to go from 90 to 0. You pay special attention between 60 and 45. Normally the patella should track straight up. If it's going up and deviating side to side, chances are there's some plica or plica entrapment. What they do for that is they surgically incise it. Then guess what happens? It grows back. Now, the next test is called your Q angle, and this is a very important test. I need some help with you. What you're going to do is you're going to take your skin marking pencil, place a dot on the ASIS. Go down to the center of the patella, make a dot. Go down to the tibial tube with the leg straight out. Where should the tibial tube be in relation to the patella?
Lateral.
Lateral. Okay? So, with those 3 dots, we're going to be able to make 2 lines. So, here is the center of the patella, make a dot. Here's the tibial tube. And the tibial tube is just a little bit lateral. Now, we're going to ask you to do that for me. I'm going to palpate the ASIS. Take your hand here. I want you to hold this here. Don't let it go. Make it nice and tight. Now, you're going to make a line. And so what some people do is they make the line the whole way down. Not necessary. All you need is about 2 or 3 inches. Okay? Now, the second line goes from, so I can take the line, run straight up to here. Can you see that? The next line goes from the tibial tube to that center. So it's this line. Hold here. Okay, just for camera's sake, it's going to look like this. Okay, now, you'll see the acute angle. Should be about 10 to 13 degrees in men, 10 to 15 degrees in women. Q stands for quadriceps, or quad Q angle, quadricep angle. After you've done that, take your goniometer. And what is the goniometer used for?
Measuring gone.
Range of motion. That was a question on your first exam. Okay? Take the grommet, place it at the center. Have this follow one leg follow one line, and the other one follow the other line. That's going to give you your number of degrees. What do we got here? 15 degrees. So he's okay. Now he's a little bit longer for a guy. I would say 10 to 13 for guys. You getting him coming inside? Now, here's the deal. Some sources actually show it go up as much as 20 degrees. But a number of the sources that I read have it from 10 to 15 degrees. Anything more than 15 degrees, you got to start being concerned that the patella is tracking laterally. And in doing so, we're going to have a problem with the development of chondromalacia patella. If I wanted you to apply a valgus stress to the knee. Now think about this. The word stress again comes into play. That's not, so who's doing the work? Okay. When I say valgus stress, which direction do I want to take the leg? Away from the midline, valgus. What am I actually stressing? So I can do it like this. Valgus stress. If I asked you to do varus stress, it would be this. Got it? How am I stressing on that? The lateral collateral ligament. So my question is, if I did a Apley's distraction test, the rotational component, that gave me medial lateral collateral ligament. If I follow that up with the valgus and the varus stress test, Waldron's can be done as a bilateral test or a simultaneous test. I prefer doing it personally as a simultaneous test. You're going to grab hold of the patient's knees like this and ask the patient to do a deep knee squat. Now, when the patient does the squat, what's happening to the tension in the quad? Does it increase? What's happening to the pressure of the tendon as it goes over the patella? Increases. So therefore, if the patella is being jammed into the patellofemoral groove and there's underlying CMP, chondromalacia patella, will I feel crepitus underneath here? Will I feel crackling and garbage and stuff? You bet. That would be Waldron's. This test is a classic test for osteochondritis dissecans in the knee. What's that? Those are those little pieces of necrotic bone that kind of cleave off. The most common site, medial femoral condyle. So with that, patient seated. You're going to ask the patient to rotate their feet in and bring their legs up to about 30 degrees. This is 0, not 30. This position here will be painful for somebody with osteochondritis dissecans where it's at the medial femoral condyle. So if this hurts, you ask the patient to do this. Like Wilson. Okay? And you have them do this. This will make the patient feel better. Achilles tap. You're going to bend the patient's knee to 90 degrees. You're going to slightly dorsiflex the foot. And then with the back side of your percussion hammer, you're going to strike. Now, what type of response did we just see? Describe it.
Plantar flexion.
Plantar response. Now, this is an orthopedic test, but it also doubles as a neurological test. And you're going to find that some of the tests that we do here will be carried over to the next try in ClinOrtho. So, what we just did here is to assess the S1 nerve root, which would be what? Disc level. L5S1. Okay? There's a test called Simmons. Simmons has another AKA, and it's called Thompson. Both of those are orthopedic relations. There is a neurological component. A neurological component is called Gordon. I'm not testing you on Gordon. You'll get that when you get over to your ClinOrtho. Test is done exactly the same way. Knee bent 90 degrees, get into the calf, squeeze the calf. What type of response do we just get? Plantar response. Why? We're shortening the muscle by squeezing it, puts a tug on the Achilles tendon, we get a plantar response. Hoffa's sign. Very simple test. The patient is scooted down, their feet are off the table. Take your palms, place them on the balls of the patient's feet, and then walk yourself up so that your legs are now touching the back of your hand. Bend your knees. And what you're doing is you're forcing both sides into dorsiflexion, and you're going to compare the amount of tension you have on one side compared with the other. Now, if it turns out that we have a calcaneal fracture, that will be painful. If there's an Achilles tendon rupture, there'll be very little to no resistance on that side. You need to know that there are three main ligaments on the lateral side. One's your anterior talofib, the second is your calcaneal fib, and the third one is your posterior talofib. They get injured in that order. Is that if we have anterior translation of the ankle, then we have anterior talofib laxity. If we now switch our hands and go push posterior, just like the PPA draw, we have posterior talofib laxity, and that's the last of those three ligaments to go, which means that that was one heck of a sprain. So the way it's going to look, take your hand like this, place it above the ankle, other hand under the calcaneus. You can push down slightly with this hand, but I'm more interested in pulling up with the other hand. And I'm looking to see, does the ankle translate up anteriorly? If it does, we have an anterior talofib laxity. Does that make sense? Then if you switch your hand position, so it was from here to doing this, now I'm going to push down. If I push down and I notice that the ankle goes posteriorly, we got posterior talofib laxity. This test is called the 4-foot abduction correction test. Take your thumb, place it on the inside of the foot near the metatarsal phalangeal joint of the big toe. And what you're going to do is you're going to push from medial to lateral. If you've got play, that's wonderful, leave it alone. The ankle and the foot will grow normally. However, there are those people that you do this, it just feels locked. Between the third and fourth metatarsal heads, you can have the development of a growth. In the Northeast, we would call it a tumor. You got a tumor between the third and fourth metatarsal head. It is a plantar digital type of tumor, it's not cancerous. But if you take the metatarsal heads and squeeze them, kind of like doing a bracelet test, it will be discomfort. So what you're going to do, metatarsal heads, lateral to medial, medial to lateral. You can do it with one hand. If you want to do it simultaneously, you can. But you'd probably be best off doing it like this and squeezing. We have two tests that go together. One's called a lateral stability test, and the other one is called the medial stability test. Take your hands and place them like this, go around the ankle like this, and now, if I am going to take this foot and turn it so the sole of the foot is going in like this, which side am I stressing?
Lateral.
So this is a lateral stability test. I'm looking to see how much play and discomfort they have on that side. If I do the opposite, what am I testing? The medial side, and that would be for the deltoid ligament. And that will come into play when we do a test called Kliger's, which is where the patient is done and seated. If you can grab the toes and make them so that they go up like this, and now you have the balls of the metatarsal head sticking out. If you strike each one of the metatarsal heads, if they've got metatarsalgia, that means metatarsal pain, they're going to jump, and they're going to tell you. Now there are things that you can do. You can try to get them off heels, very unlikely. You can end up getting a metatarsal pad that goes underneath and circles the metatarsal edge, and we're walking on that. That would probably be the next best thing. And then you can have an orthosis made that takes care of the arches as well as the metatarsal edge. So that is called the metatarsal test. Most people, when they do this the first time, have their hands too high up and they're doing this. The way you do it is just yank it on the ankle. What I want you to do is place your thumb, not like this, but like this. So that when you're doing this, the motion's happening at the metatarsal phalangeal joint. You just be quick. This will be jamming a metatarsal head. This is another part of the metatarsal joint complex, and you're going to end up having an increase in discomfort. If you end up going to your medial malleolus, go a little posterior to it and superior to it and strike. This is Tinel's test in the ankle, and that is for compression of the posterior tibial nerve. And here was median, ulnar, posterior tibial. And the pain patterns can be from the point of irritation down the entire sole of the foot, except for the medial longitudinal arch. If you take your DP cuff, place it above the malleolus, going up onto the calf, and you pump it up until you no longer feel a dorsal heel pulse. And you keep it there for 2 minutes. This test is called the tourniquet test, and it is designed to simulate the irritating factor to the posterior tibial nerve. So this patient will also feel distal to the compression, pain running down the foot, the entire sole of the foot, except for the medial longitudinal arch. All I'm doing is taking the foot and pulling it out so that the medial side of the ankle is being stressed. That is called Kliger's or Kliger's, and it's known as the best test for deltoid ligaments. What you do is go above the ankle, below the ankle, and shear it from side to side, and compare it to the opposite side. There should not be any side-to-side motion. Take a look at his foot, and you'll see that the arch is collapsed. Somebody like this, if you're going to have orthoses or inserts made, you got to make sure that the arch should be supported only if the arch is supple. So what you're going to do is you're going to ask the patient to stand with one foot in front of the other. You're going to ask them to go up on the ball of the foot. And what you're going to do is look from the side and see, does any of the arch return? Turn the other foot to the shoulder. Great? Yes. It returns, not great, but it's returning. That means there's a little bit of suppleness to it. That's a good thing. Patient's going to come in, they're going to complain to you that their leg feels maybe a little hot, a little bit swollen, maybe a little bit doughy compared to the opposite side. That's their complaint. You're going to take your hand, place it on the top of the calf, and you're going to push the calf into the tibia, and then you're going to pull the calf off the tibia. That's the entire test, unlike a fist breaking test. In people that have the potential to have thrombophlebitis, the vessels in the leg are very, very tender, very, very irritated. Pressing on the calf is going to push those vessels into the tibia. That's going to hurt. Pulling the calf away from the tibia is going to make the patient feel better. Homans, H-O-M-A-N-S, and it's the most popular test asked when it comes to vascular testing. Then comes band close. So this is how it looks. Raise it, dorsiflex, squeeze. If the patient has a problem where the actual blood vessels in here are irritated, what's going to happen is this is going to hurt here and here. It's not going to improve. Okay? So what we're looking for here is this. This test is similar in design to doing a Dreyer's test and or a Kaplan's test. Dreyer's test was for what? Patella fracture. Kaplan's test is for what? Lateral epicondylitis. Okay? So, you take a look behind the leg, And he does have a little bit of varicosity here. You can see it sticking out. For most people, that's not really discomforting. It may not be pleasant from a cosmetic perspective. And that's why some people go in from a plastic surgery perspective to get the stuff taken care of. But in some people, the actual varicosity becomes painful. And then if the patient coughs and sneezes, cough and sneeze, and he says it hurts, and you say where, and they point right to the area where the varicosity is. What's happening is you're increasing intravascular pressure. So you're making it go down with more force. It's meeting the blood coming up this direction, and it stagnates, and the vessel kind of blows a little bit more. So what you need to do on this test is, if this was the varicosity, go above the varicosity and squeeze, just like doing a Dryer's test and a Kaplan's test. And now ask him to squeeze again, cough again. What we're doing is we're trying to help prevent some of the backflow of the blood down into the leg. The patient should feel better second time around. Now, this test here, folks, it needs to be done simultaneously. In practice, you'll be able to do one leg at a time, but the way the test is designed, they want to see you do both legs at the same time. So you need 2 leading thumbs. So, you get something like this on a practical or on a clinical exam, you need to borrow the other equipment from the person that's going to be with you. If you don't have to. You either place it around the calf. Now, simultaneously, what we're going to do is we're going to pump this up to about 180 millimeters of mercury. You see he's at 180 millimeters of mercury. Okay? So, the person that has a problem with vascularity inside their legs, they will not even allow you to attempt to get this up to 180 millimeters of mercury, one side compared to the other. So this will be a very painful type of test for the patient that does have vascular problems inside the leg. And in this case, those vascular problems result in the ability to form a clot. So it's a thrombosis. So there's a certain way that you're going to need to apply the tourniquet so as to not really cripple your patient. Start with the leg like this. When it's like this, both hands are free. You're going to take the tourniquet, and by the way, I got these from my supplier in Plano, so I will supply these for the test if you have one, but I do need them back. Okay. Now, you're going to start by holding them in digits 1 and 2 of both hands. Take digit numbers 1 and 2 on the right hand, bring it over so now it's being held by digits 2 and 3 of the other hand. Now I'm not going to move. It's flat on the back of the leg. I am not going to move my hands up and down. I'm keeping his hand to steady it. All I do is release my thumb on this side here, keep releasing, and pull it. He's telling you, it's getting quite tight. Now look at how much longer this is. Just take it, make a little bit of a loop, slip it underneath, get your finger out, and it's good to go. Now, this is not pulling, it's not rolling, it's not doing anything on the leg. If you did it right, you should have no problem. Now, once it's on the leg, put the leg down, and we're going to look in here for the saphenous. If it does, then get up, you march around, laying down, is it gone? If it's gone, the muscles are doing their job, and the valves are counted. This is a test for the potential to form a clot. Again, take your DP cuff. Now you're going to place it around the patient's thigh. What you're going to do is you're going to pump it up to about 40-45 millimeters of mercury. You're going to keep it there for about 2 minutes. Now, when we do that, we're causing an impedance to venous return. When the patient complains of pain, that's an indicator that they have the potential to form a clot. That would be thrombosis. It's called Trendelenburg. And again, what you're going to do is you're going to have your patient supine. You're going to take the tourniquet, apply it the way I showed it to you a moment ago. we'll ask the patient to stand. Don't stand. And then what you're going to do is after he stands, you're going to pull the tourniquet off. And you're going to look to see how fast blood flows down into the leg and then these veins just stand. Not a very pleasant experience. It's called Trendelenburg. We'll do the last Lippmann. What I'd like you to do is have your patient seated. You face your patient and place your thumbs on their mastoid and squeeze. You need to face your thumb. It should be your thumbs. Okay? If the patient has an over-exaggerated response, think malingerer. So patients, point to something where you can't see it. Okay, doctors, what are you going to do next? You got to really kind of distract them. Then ask the patient to lie down prone. Now ask them to point to it again. Magnus. Now, don't ever call your patient a malingerer. They don't like that. But you can be honest and say your objective and subjective findings don't seem to match. With your patient seated, palpate the radial pulse. Now, everybody's got neck pain right now. Okay, so with your other hand, get on the neck, palpate heavily. Under the guise of palpation and examination, you're basically mechanically irritating the area of main complaints. If they truly have pain, what's going to happen to their sympathetics? Kicks in, what happens to their pulse rate? Goes up, they're not faking it. Even before he bends. Bending of the lower back, the hip, the knees, is really easy for most people to do. The people that are thinking of this test as being too involved, they're the ones that you're thinking about as being malingerer. So hold on to the ankle, have them bend from the waist to the hips and everything, on the knees, no the other one will stop, touch the ground, come on back up, there you go. Okay, so that is Burns bench test. The person that really does not wish to do that, they're faking it. The person that may have a disc lesion will at least attempt to do that because they don't know what they're going to feel until it happens. And they say, wow, you know, it's really starting to hurt. I come back up. That's a person that's a legitimate patient. See the other one. Paresis means weakness. So let's say this is a weak leg. If I take my hand and I place each hand under the heels of both legs, like this. Now I'm going to ask the patient to try to lift the weak leg, so lift this leg up. In order for him to do that, if it's weak, he's going to have to recruit some other muscles, isn't he? So what should I feel in this hand? An increase in pressure. If I don't feel an increase in pressure, kind of proportional to what they're saying, how weak their leg feels, I'm thinking this guy's really able to get the leg up without the increase in pressure. The guy's faking. This is called Hoover's.